Broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Welcome to this seminar. We're going to wait a couple of seconds so that everybody who is registered can get in, and then we'll get started. So just give us 1 or 2 minutes. All right, well, again, good morning, everybody. Welcome to today's webinar, and thank you for joining us. My name is Alexandra Vandenberg, and I'm the Associate Director at the Michael and Susan Delft Center for Healthy Living. And today's webinar is hosted by the Michael and Susan Delft Center for Healthy Living at the UT Health School of Public Health in Austin. And the center's mission is healthy children in a healthy world. Before we get started, I just want to make some housekeeping announcements. This webinar is being recorded and will be archived along with the presentation slides on our website, which is at msdcenter.org. And if you have any questions during the presentations, we're asking you to enter them in the chat box so that we'll have time, and we will have time for questions and answers at the end of the presentations. Our speaker for today is Dr. Linda Lee, who is a public health professional with a focus on opportunistic environmental pathogens. She's currently the Chief Medical Affairs and Science Officer at UV Angel. And I will hand it over to Dr. Lee to start her presentations on contaminated air, the invisible threats to patients and healthcare workers. Now, are you worried about air? So, Dr. Lee, you've got the floor.
Thank you very much. I appreciate it. Hopefully everyone can hear me okay. I'm going to cover a lot of slides today, and I know that many of you, this is not a new area. You may have attended my last webinar, which really focused a lot on a lot of the research that I've done in healthcare. And I've spent literally a career, if we could go to the first slide, Kate. Actually, the next slide. I've actually spent an entire career studying the environment and really looking at ways that the environment impacts workers, hospital patients, pretty much any type of environment, and really looking at opportunistic environmental pathogens from a standpoint of we put all these controls in place in healthcare, yet we still have infections. And what's causing those? We're going to talk a little bit about research that's out there. We're going to do a little level set on where we are with the current coronavirus, and then some of the information on how you, as either a practitioner or an individual, are looking at protecting yourselves, particularly as you're looking at airborne controls, because at the end of the day, there's probably 1,000 things coming at you. A little bit of my background is that I'm currently adjunct faculty at the UT School of Public Health in the Department of Epidemiology, and I'm really excited about that because this is not only my vocation, but it's my avocation. I really believe in it. And I've spent a career, I'm also certified in infection prevention, infection control, and my practice is really in public health, and I have a consulting company. So let's go to the next slide. We have a few learning objectives. And these are very loose because, you couldn't do a presentation without learning objectives. So we're going to talk a little bit about SARS, particularly COVID-2, a little bit about coronavirus, but I'm sure you guys have coronavirus fatigue. We're also going to talk some about the air and how it contaminates, because I look at the air holistically in relationship to surfaces and everything else. We're going to go through a lot of this quickly, so hopefully you've come with your questions, but if you note at the end, I do have an email. You can also talk to me directly. We're going to describe some of the dangers of pathogenic particles and what they pose to people, and some really things about infectious doses and what we think we know about infectious doses, but how many things complicate this whole issue of airborne versus not airborne, and what week is it, and is it airborne or not this week? So we're going to talk a little bit about that. So our learning objectives are pretty straightforward, all around COVID, all around the air. Next slide. I have a different slide, but let's go with this. So we're going to review the SARS-CoV-2. So what we know about from a virology standpoint is that it's a single-strand positive sense RNA. And why is that important? Well, in industrial hygiene, RNA is really hard to find in the air. So in many cases, we use RNA because you can get it off of surfaces much easier. But the fact that it's a single-strand RNA doesn't necessarily mean it's not in the air from collection and sampling. It's just harder to detect in the air. So sometimes when you read a peer-review article, it becomes important to look at the sampling methodology. So if someone's making a conclusion, which, of course, statistically we should be looking at those results anyway, but that becomes important. It's thought to be mutating quickly, similar to other emerging viruses, novel viruses. It binds to ACE2 receptors, so that's why it seems to have an effect on the kidneys, the myocardium, and the lungs. 96% of it represents similar genomes to what we see in other bad coronaviruses. And we know that coronaviruses are somewhat naturally occurring. They're pretty much everywhere. They cause colds, but we usually adapt to them pretty well. But this is a novel virus. It seems to be pretty adaptable in the environment. And the reason why that's important is that as people make statements saying, oh, it only lives this long or it only lives that long, that may change. And a lot of information that we have is changing on this virus. We know that it's a large genome, which is important because that affects the transmission between humans and animals. So the larger the genome, obviously the transmissibility. A little bit about transmission. We primarily thought that maybe it was droplet, but there are some real distinctions because at least in the world of particle science and things like that, we make distinctions between droplets and aerosols, and same thing with infection prevention. So inhaled aerosols are usually greater than 100 microns in size, and they usually don't get much past the nose, and that's where they kind of live. Thoracic aerosols, which are aerosols that are less than 10, but between 10 and 15 microns, they get past the nose and usually end up in the larynx. And when you get to respiratory aerosols, we're usually thinking about those in less than 5 micron size. And of course, they enter the terminal bronchiole. And so what you end up with is these little different sized particles, but these size particles are very much dependent on a lot of things. And we're going to learn a lot about that today. We also know that close contact, and we see this with droplets. You touch things, other people touch things. Surfaces, it was originally reported by NIOSH and CDC and some others as 0 to 3 days. But we found that in studies on the Diamond Princess cruise ship that these pathogens lived up to 17 days after the passengers were actually evacuated from the ship, and they were still there. And really the role of temperature and humidity, and this is why this becomes so important as we move into the winter, becomes so important. But now what we're being told by CDC, depending on the week, is that it's airborne. So what does airborne really mean? And what does it really mean to us in the public health realm when we're trying to prevent infection? Because that's really what we're doing, is we're trying to access the best technologies to prevent infection, both to the people, reducing the amount of biological loading, and so forth. So next slide. Some about the pathogenesis of SARS is that we know about a week, people start shedding viruses about 1 to 2 days before they have symptoms. They're probably pre-symptomatic phase. We also know that as these symptoms emerge, the ability to invade the respiratory and digestive tract, i.e. why we have the type of symptoms we have, is pervasive as we go back to the size of the particles we talked about. It's reported by many that the disease is self-limiting to 90–95% of the time. People get sick, they stay home, they recover, they move on. 25 to 50%, and this number moves, and so you know, I think it varies depending on which expert you listen to, are people who are asymptomatic. And it's interesting, we'll talk about this a little bit out of some studies that were done by Fort Detrick in the 60s on influenza. Depending on the site that the pathogen actually lands, actually may drive some of this asymptomatic modality. So then people, it's thought that between 5 and 10% of people, or as high as 15%, will develop bilateral pneumonia, oxygen desaturation, and then potentially ARDS or multisystem organs, and then death. But I guess if there's a good news to this virus is that a lot of people will recover, not just to mention that we're learning more and more about maybe some longer term effects, but I think we're learning more about this all the time. So let's go back to routes of transmission on our next slide. So we have direct routes of transmission, and most of us recognize this is usually respiratory, exchanging inhaled particles from different people. And so when you are in a room, I'm sharing my exhaled particles with another person, whether that's talking or coughing or sneezing. But if I'm a healthy person, but I'm susceptible, I probably will or have a good chance of getting this infection. The indirect route, which is where we spent a lot of our initial time of cleaning surfaces, and you know, your Amazon box comes, everybody wipes it down or lets it sit in the sun for a few days, doesn't seem to be as pervasive as originally thought. It still is, obviously. Anytime you cough or sneeze, or you have contamination on your hands and you touch another surface, and then an otherwise healthy person but susceptible touches that surface, and then touches their eyes, their ears, or excuse me, their nose, their mouth, you have what is called touch transfer. And then touch transfer, that's why we wash our hands. That's why washing our hands is one of the #1 infection control things we can do in any situation. So the countermeasures are, of course, direct would be masks. We're finding that masks, whatever type of mask, is offering a lot of protection, not only to the person who is infectious from spreading it, but for people who are not infectious from potentially getting it. It's been amazing, some of the studies that have been done, and the level of protection, even with simple barriers. But of course, air treatment controls, barriers, social distancing, outdoor air dilution, we're seeing this all over the place. You can't go anywhere where you're not seeing some of these controls every day. And then of course, indirect. And that's cleaning, sanitizing fomites being inanimate objects, hand washing, and certainly avoiding touching your face. I've seen some studies where people can touch their face up to 100 times an hour. And it's certainly not conscious, they don't even know they're doing it, but they rub something. And this is going on all day. It's sort of the cycle of disease transmission. The next slide. But everyone on this phone who, or this call, who's a nurse or a doctor or a public school teacher or whatever your occupation is or whatever you do, you'll know that this whole complex issue of disease transmission occurs all the time. There are people who get sick and there are people who don't get sick. And why is that? What makes up that? Well, we normally think of susceptible people as either old or young. What is old and what is young? We think about people with comorbidities. What comorbidities apply? And so the people who are infected in this particular case are potentially spreading to this whole other group of people. And we've now narrowed a lot of this to indoor close quarters, what we might consider to be super spreader events. We also have those outdoors. But where people in particular are sharing spaces, I saw a study in CDC that said that maybe up to 40% of new infections are occurring places like restaurants, and places where people de facto are just close and there's indoor transmission. A lot of this dependence is dependent on ventilation and air movement and a lot of other things. And then of course transmission, or what's the pathway for the disease, and then high touch surfaces or fomites as we might think of them. Next slide. The whole asymptomatic spread model is really interesting with this disease because we know that there are quite a few people, and I really think about some really interesting studies from the 60s that were done at Fort Detrick. And in the 60s, they said, well, depending on where the viral particles land, they showed that the infection rate was quite different. So you might only need one TCID50 to make a person who is susceptible get an influenza infection with just one dose if it gets directly into their lungs, so if they breathe it in. On the other hand, they did the same studies and they said that 100 doses of a TCID50 for influenza particles lasting in the nose created a lot of either very mild or asymptomatic disease. So it's really interesting to understand where the disease potentially, again, this is all new, we're trying to figure this out in relation to stuff we already know, but how much of this is actually going to make you sick? And sort of these asymptomatic people may just be responding based on where the pathogen actually landed in their respiratory system. Pre-symptomatic persons, we know, have high enough viral loading to spread disease. We're going to look at that at some of the following slides. They can have similar viral loading, but they have what are called viral or viable virus circles. And so these cycles are between high viral particles and low viral particles, depending on how they're cycling in these asymptomatic people. Also, the risk of transmission, we know, is, or seems to be, 2 times higher if you're symptomatic, coughing, sneezing, because of the speed and the particle distribution within the air, and we're going to talk a little bit about that. Also, the viral loading is recognized in some of the most recent studies. There's a really kind of cool paper called Wrong Place, Wrong Time, Wrong Disease. And it basically talks about as little as 7 shedding viral copies, 10 to the 7th viral shedding copies could be making people sick. And so depending, again, where it lands, how you get it, your susceptibility, all of these things will play a role. And we also know that people infected with the current coronavirus will expose more people as they get to these physical contact networks, i.e. why we do contact tracing. And so even people who don't show infections because they become asymptomatic can then spread them. So following this whole chain is that we're always looking for people who are sick. And it may be that we need to be looking for people who are not sick. And so it makes these whole contact chain or contact following much more difficult when you're looking at aerosolization. So let's look at the next slide, which is on super spreading events. And there's lots of them. You can read about the Rose Garden. You can read about all sorts of super spreading events, from church singing choirs to funerals. But I read this one as the latest one because many of us in the public health community were really concerned in August about that Sturgis motorcycle rally that occurred in South Dakota from August 7th through the 16th. And we saw that the secondary attack rate was 35%, with a range between 27 and 44. But interestingly enough, there were 460,000 participants. And at least in this study done, they estimated that 266,000 of those people plus were associated with cases. So either symptomatic, asymptomatic, they were involved with this motorcycle rally. But when we think about the cost of this to the healthcare system, 19% of the 1.4 million cases at that time of COVID were related to this one event, $2.2 billion. Now, again, this is somebody's research interpretation of this data, but that's really what many of us in public health go on, is that What is the data telling us? What is it suggesting to us? Doesn't make it 100% true. It makes us think as public health practitioners, wow, what is the impact of these events? And then as practitioners, how do we interrupt those impacts? How do we actually impact the prevention or the disease transmission or the interruption of these diseases? Next slide. So I'm a real believer in source control. Now, source control is much easier if you know the source. And so when you're looking at this, and you're looking at this in particular, and this basically shows the relationship between viral copies, primary transmission, secondary transmission, and interestingly enough, this issue of this thermal plume. So when you think about it, when you think about turbulence in the air and you think about air movement, you can wrap your head around this. And this is a lot of research done by Lindsay Marr out of Virginia Tech. She does a really, really great job around this. But if we think about air movement and we think about distance of travel, air movement at 20 centimeters per second. So this is somebody coughing or somebody sneezing. Let's go to the next slide. The 5 droplet micron size particles will travel between 65 and 270 meters. So when you look at that and you look at these little particle sizes, 10 microns when you're coughing or sneezing will travel up to 15 to 60 meters. And when you're looking at 20 micron size, they can go, 15 meters, or 30 micron size, which are much larger, 2 to 5 meters. So this whole 6-foot thing, when you think about it, is sort of relevant to the size of the micron or the particle that you're expelling. So at 20 centimeters per square, 20 centimeters per second, the turbulence also in the air affects the distance of travel, but does not necessarily affect the settling time. And we're going to look at settling times a little bit later in the presentation. But this thermal plume that people have, that and both Marr and Milton from the School of Public Health at the University of California, San Francisco, when you look at this thermal plume, we can add then to this particle movement. So like, for instance, a 50 micron sized particle or droplet, like you might see here, has basically an upward velocity from the body. So it goes up into the air further. And then what happens is the settling time changes for that micron size. So when we look at NIOSH settling times and we say, wow, how long is it going to take for this to be in the air and for it to settle? So as we go further into this presentation, you're going to see where this information really impacts how you design your protocols around protection. So as I had mentioned earlier, studies out of Fort Detrick, New Jersey orphanages, and the Maryland Penitentiary in the 60s showed these viral copies, very, very small amounts of TCID50s, depending on where it landed in your breathing zone, and whether it made it past your nose, whether it made it to your larynx, whether it made it to your bronchial, really affected whether you were an asymptomatic person or you had full-blown disease. In those studies done in the 60s, they shown that people with full-blown disease could have as much as one particle, one aerosolized TCID50 that would land in the lungs that could make you sick. So these are really important aspects when you're looking at controls. And I'm only putting this out there because it's a complicated situation. So when people try to make these fine lines between droplet and aerosol and particle size, and there's so many things that affect that. And so making these sort of hard lines in the sand, this is droplet, can be so impacted by all of these other things that we talked about. So let's look at the next slide. Many of you are very familiar with this. This is basically NIOSH's hierarchy of control. And when we're talking about disease, We might have elimination. We might be able to eliminate it. That's usually not the case because it's there. And we don't usually have substitution. So I can't substitute a coronavirus for a TB and say, hey, we're good. So what we want to do is we want to really look at the engineering controls, the administrative controls, and the PPE. So we know what engineering controls are things that don't involve an employee or a person or anyone having to do anything. So if you could think about it in the simplest terms, the engineering control in your house might be your heating and air conditioning. You set the temperature and then it just tells you if you want to be hot or cold, that's the temperature. In public buildings, you set the temperature and it decides hot and cold based on the temperature. So those are engineering controls. Most of you who work in buildings or offices or schools, you can't even control that. Somebody sets it and it just goes. Administrative controls, of course, are cleaning, things that you do to protect the environment, people have to engage in. And some of that has some normal bias, depending on how well you train people, depending on, you know, the level of sophistication of the people implementing the mitigation. And then, of course, we're dealing every day, as many of you know, with PPE, because there's not enough of it. Is it the right? Do the people wear it right? And so many of you are very familiar with issues associated with PPE. So these are the recommendations. Next slide, please. All right, so what does science tell us about high-touch surfaces? Because people have studied high-touch surfaces for years and years and years and years, but we never put them together with the air. We put them together with droplets, we put them together with touch, we put them together with a lot of things. And one of my clients works in UV, so I've studied UV extensively. And so what science tells us is that a clinician or a person in a healthcare environment, and certainly this could apply in any environment, but they have a lot of shared surfaces. So a clinical person can touch the same computer by different people 115 to 130 times, and this is published in the American Journal of Infection Control. And the most touched product in healthcare is a medical card. And the reason being because it has a keyboard on it. And people type onto it, they enter their notes, they do all sorts of things. And keyboards are often, in mice, harbor more diseases. So if you're in a library in a public building, one of the ways that people are mostly going to get sick is touching keyboards in mice that are shared spaces without controls or without decontamination programs. Study of airport kiosks. Interestingly enough, I'm working on a project to develop self-decontaminating airport kiosks so that all of this high-touch CFUs that are transferred from one people's hands and other people's hands onto surfaces, from toilet seats, from everywhere. There's actually more on the kiosk in the airport than there is on the toilet seat if you visit the airport. I wouldn't recommend touching or licking either one of them, but just it's sort of an FYI. So next time you're at a party and somebody wants to know, hey, how many CFUs are on the toilet seat? So when you look at other surfaces, if you look at samples, for instance, we looked at bacterial samples, we looked at a whole bunch of other samples. And what percentage of those, because there are bacteria that are sort of naturally occurring, what percentage of those are healthcare associated infections that we track? We track. That's a big issue in healthcare. We track. At least 25% of them will have high enough levels of healthcare associated bacteria. And so when we look at these studies, next slide, we looked at this shared medical equipment, and we know that the number of interactions, the transmission from medical equipment and other fomites are all direct paths, are all direct opportunities for contact with pathogens of concern within healthcare. So shared medical equipment. Well, this would apply to anywhere that you're sharing things that people are touching. Next slide. So we talked a little bit about these controls. We know that hand washing is an administrative control, teaching people to wash their hands. So we know that CDC says 20 seconds. You know, my watch tells me when I'm washing my hands and gives me a timer and says it's 20 seconds. Well, not everybody washes their hands for 20 seconds. Not everybody uses soap. Some people use hand sanitizer. Hand sanitizer will work on some things, but not everything. And so soap and water, 20 seconds is our best practice, but we know there is a lot of bias in the way people do that. Daily cleaning, what does daily cleaning look like? You know, depending on where you are, daily cleaning could be emptying the trash in the room, and that's about it. We hope that people, especially during this COVID time, we know that if somebody tests positive, they bring in a SWAT team and they do deep cleaning. And so they theoretically are doing deep cleaning. But all of these steps have bias depending on the level of education, the level of engagement, the level of knowledge, and quite frankly, the materials used to clean. So this is why administrative controls are second to the last on the hierarchy of controls. So let's move to the next slide. So right before the COVID event started and all travel ceased as we know it, I was studying a series of hospitals in Maryland, and I was looking for clinically relevant microorganisms on high-touch surfaces. So I was looking at wows and cows and wall arms and keyboards and nurses' station and patient monitors and Pyxis machines and all that. And some of you will know what that is and others won't, but that's all high-touch things. People are interfacing with this all the time. So the average number of CFUs on a surface, and we sampled basically 2,000 surfaces, and we didn't control for cleaning, so they could have just literally been cleaned, but we randomly picked almost 2,100 surfaces, and the average CFUs on there were about 111. Now, in a healthcare environment, that's probably normal to maybe even a little low, but it's because 30% of those samples had nothing on them. And so there could be sampling error, there could be bias because of the way you sample for surfaces. And so, but what we found was there were a lot of clinically relevant bacteria. The lab that I use, which is the VA in Cleveland, they'd like to call it the fecal veneer. There was a fecal veneer, the Enterococcus, fecal veneer over everything. What that tells us is that maybe people aren't washing their hands. So when you look at these numbers, it tells you that even in the cleanest spaces, without dealing with children in school and restaurants and all this, you've got lots of stuff that can make people sick. Now there is some bias because people in hospitals are sick, but theoretically, these can be found in the environment. I'm doing studies right now in Starbucks and McDonald's. And so when we look at these environments, they're not necessarily that different. Next slide. But my really big area of interest is the relationship between air and surfaces. Because in the infection control world, we like to make distinctions. Droplet, we control for this way. Aerosol, we control for this way. Contact, we control for this way. But I postulate, and I believe my research supports, that these two environments interact with each other all the time. Air kicks on, stuff that's sitting on surfaces gets re-entrained, eventually settles out. You can see this when you clean your house. When you clean your house, you stir up all this dust, and in an hour, all these little particles you can see coming in through the window are gone. Well, they didn't go away. They just settled out of the air. And so I believe we have to deal with environments holistically. We don't want to move them from surface to air and air to surface without ultimately treating or getting rid of them. Next slide. So I think of the air as the invisible threat. And if you tuned in for the last of my series, we talked about each one of these areas and the fact that there's all sorts of ways things are transmitted. I'm really interested right now in this whole fecal transmission route and viral loading and shedding from human waste, because in 2004, you studied the apartments that were part of the original SARS outbreak, and it was originally tied to fecal contamination from the stacking of toilets in that building. And so a lot of information about, flush the toilet, put down the seat. Well, we can't flush the toilet and put down the seat in a public restroom. So what are you supposed to do? Flush the toilet and run like heck out of the room? Well, then you didn't wash your hands. And so we've got this real dilemma going on with toilets right now. But I'm following it closely because some of these less than obvious, and NIOSH has some really great things if you're in healthcare and you want to see about toilet flushing and getting stuff all over the front of you. When I was at MD Anderson, we did some studies with toilet flushing and hopper flushings where we used glow gel or some of those bioluminescent identifiers, and we flushed them and we could see it all over the front of people. So we looked at practices to avoid that. But anyway, so these are what I consider to be the invisible. So let's go to the next slide on what science tells us. And I'm trying to move so I can get to questions. But what science tells us is that in all the studies I've done, I've got 5 peer-reviewed studies in the last 4 years in this area, that the air is often more than 8 times more contaminated than surfaces. And the reason being is that we clean surfaces all the time. I've got Clorox sitting next to my computer here. I'm the only person who sits in this office, but I Clorox my computer keyboard all the time because I might be leaving something behind that's going to make me sick. We also know that after cleaning, especially from a particle measurement standpoint, now particles are not viable, so we're not equating particles environment, we're looking at it more as the total microbiome, and all microbiology makes up this sort of science. But if you look at that, particles can be stirred up after cleaning, particularly in a patient room. This was published by MD Anderson, a study I did in the early 2000s. And particles were most active 1 hour after cleaning. So when you think about cleaning and you think about moving all these things around, we look sometimes, especially in high-risk areas, of repopulating a room or repopulating an area immediately after cleaning, whether or not that's a good idea. So when we look at how long the coronavirus, and we said up to 3 hours, well, we know that just by coronaviruses in general, the reason why NIH came out with that, if you read the study, and I'm on a committee with the guy who did the study, he's with CDC, and basically what he's saying is that we cut the test off at 3 hours. And so we know that coronaviruses in general, we can see depending on particle size, and we'll look at that in a minute. MRSA, influenza, you read it, there's like thousands of publications on this. The next slide. Everyone on this call who's familiar with public health or disease transmission or pretty much anything is going to know that this is the normal interruption of disease. So what we're focusing on are pathogens that are left behind. So we can't really do much about the pathogen. We can't really do much about the source because, unless we're using source control as my favorite thing, like masks and so forth, people have a portal of exit, even if it's me just talking or you just talking or sneezing or singing or whatever. Well, where they're left behind. Now, these are the steps we can take to interrupt this disease transmission. So we need to interrupt the route of entry, i.e. a mask, a way to protect ourselves. We need to take care of our susceptible hosts. So people who know they're either susceptible, they're going to take special precautions. And then, of course, pathogens left behind. And so if we clean spots, if we do all the right things, it's like the fire triangle. We want to interrupt one of these pathways, any one that we can, to try to prevent this disease from being transmitted. Next slide. This is one of my favorite slides because, in healthcare and pretty much everywhere now, we ask people if they wash their hands. Ask your healthcare practitioner if they wash their hands. Well, this meta-analysis I did on a whole bunch of studies on prior room occupancy, and these are some pathogens that we're concerned about in healthcare. In these studies, it basically said the prior room occupant actually drove whether or not the likelihood of getting a healthcare associated infection with this pathogen. So if you look at Acinetobacter, for instance, right here, 3.8 times higher likelihood that you will get an infection if the last person. So if we've totally cleaned the room, permanently cleaned the room, use robots, use all the things we use in our arsenal of cleaning, where is this coming from? And my suspicion is that it is in the air, and it travels in the air. It finds a nice little place to hide that's not high touch, and then all of this room activity and turbulence re-entrains it into the environment. You have all the susceptibility, all the things we just looked at on the last slide, and that's where these little bugs are coming from. So when we look at this and we think about this in terms of what we're doing, this is not a one silver bullet is going to fix anything. It takes a village. And that's what we're going to talk about as we move forward, is what village do we have in our toolbox to try to help us prevent this, particularly in communal settings, particularly in environments where we've got, bunches of kids, or we've got, we've got healthcare environments, or we've got a restaurant, or we've got any indoor space where we're looking to protect people. And knowledge is power for us in this public health arena to try to look in this toolbox and make the right choices. So next slide. So the thing I like to show on this slide is that the difference between continuous treatment and episodic treatment. So episodic treatment is the housekeeper comes in tonight in your office building and they wipe things down and they empty the trash can, or the janitor comes in after school and mops the floor, and maybe they do a higher level of cleaning. That's episodic cleaning. So the room, let's just say, is terminally clean. Let's just go with that. So the room is terminally clean. Now the kids come back to school, people come back into the office. So this microbiology, or this microbiological loading goes up as the more people come in. And as the day goes on, this loading is really high. And let's say this is a hospital room, patients come in, visitors come in, staff comes in, everybody comes in. This loading continues to grow, and then they get discharged, and then we terminally clean the room again. So this is the end of the day, we terminally clean the room, and we're ready for the next person or the next day. Well, this is episodic cleaning. So the risk, so if you're looking at risk, and we don't know what the risk ratio or the odds ratio are of getting sick because of all the factors we've already talked about, but let's just say we're at the 50%, or we're at the mean, that as this level goes up, theoretically, your infectious dose also goes up. Therefore, your risk goes up. Well, if you're looking at continuous cleaning and technologies that continuously clean, so there's technologies that continuously clean. Maybe you have one in your home, or you have one in your air handler might run all the time, or your office building does. There are things that do continuous cleaning, but many times those aren't at the source. So if you think about an air handler, and the air handler is constantly changing the air, and the air handler is constantly filtering the air, but what happens is it's not at the source. So it's treating every single room the same, and we're going to look at that. Next slide. I like this slide because a lot of times I consult with people who are trying to figure out what technology to get. And so when people do lab studies and they say, oh, we're 99.9999159%, it's in a laboratory setting. So they inoculate the environment, they seed the environment, they treat the environment, they do whatever with their technology, and they say, hey, we're 99.999. But we know that 37 million bacteria are being shed every hour by people. It's well studied. So if you can think about the environment being a bucket and the hose being in the bucket, you terminally clean the environment. So let's say there's nothing in the bucket. Throughout the day, this builds up, the water builds up and eventually overflows. So what continuous treatment does is it continually lowers this. It's never, and I rarely use the word never, but it's never going to be the way it's tested in a lab, because it's constantly being seeded. So unless you sealed the room, didn't allow any more air in, didn't allow any more people in, and let it run, or let the technology run, or let the chemical work, it's never going to be zero. So understanding this whole risk ratio, that what you're trying to do is mitigate as many of these pathways as you can, constantly reducing this number. Next slide. So here's the problem. I'm going to talk about air, we could talk about chemicals, we could talk about anything, but because air is near and dear to my heart, because everyone has to breathe, air technologies are really significant to me. And I focus my energies on air technology because there's just so many things coming at us every day, especially in this coronavirus season. So next slide. So air as a pathway is well established. We know that CDC studied well child visits, and said they account for over 700,000 collateral new cases a year of people being sick. So when you look at that and you say, wow, you know, that's just from going to the doctor's office. Even if they have a wall that says clean side and dirty side, there's rarely something that's not, that's where they keep the dirty toys versus the clean toys. That's not necessarily that they've designed their office to have airflows going in all the correct directions with the correct controls. We see this, I just did a study at the VA in Houston on aerosol generating procedures in dental. And we had really an interesting study because they had the max controls that you would never see in a normal operating conditions. And we still could see high levels of concentration on surfaces, much better than when not everything is covered in plastic and not every person is in, you know, a hazmat suit. There's some really interesting studies on Alzheimer's and fungus. And so air to me is a really important thing. And so I focus a lot on air in my practice. Next slide. Next slide. Okay, so my next slide, and I just stick this in there for your benefit. This is just sort of the FDA/EPA's resistance of pathogens. And this is basically based on chemistry. But I stick this in here because when people will tell you, because some of you on this call probably are evaluating technologies, this is how resistant. So if you look at the world of envelope viruses, which is what we're dealing in now with coronaviruses, it's the least resistant on this list. But when you're evaluating technologies and you're looking at particle size and you're looking at all this, this becomes an important thing to know. How did they test the technology and what is it tested against? And you can find a lot of this under EPA and FRIFRA. It's also in FDA, but I put this in there just for the benefit. Next slide. This is actually a NIOSH slide, and this is where we talked about particles. And I find this to be quite helpful when you're looking at controls. So if you look down here at the very bottom, and you look at these, so a 0.5 micron particle is going to remain suspended in the air. This is still air. This is with no air moving for up to 41 hours. So when we look at the size of a coronavirus, a coronavirus being at 0.110, it can be airborne in still environments for a really long time. Now, why is this? Why do you say that? And you say, huh, well, how's that? Well, what happens is that as we expel particles, these particles are laden with pollutants. They could be mucus, they could be moisture, they could be anything. As the humidity and temperature in the room change, these pollutants dry away. So whether it's moisture, so if it hasn't landed, if it's small enough and it's not landed, even if it has landed, as these moisture and these mucus and these particles sort of evaporate around these particles become smaller and smaller and smaller till they get down to what their normal micron or their expected micron size is. So they could start out pretty big, but as this happens, as this normal physical transformation occurs, they get down to their normal particle size. So these particles really are quite important in still air to understand at 5 feet, which is breathing zone. For some that might be vertically challenged like myself, 5 feet is my breathing zone. And so when you look at that, you say, oh, okay, so that could be in the air from me expelling this for up to 41 hours at 0.5 microns. Next slide. So for one of my clients, I did a study and I looked at that raw viral particle size against pathogens that are of interest in my research. So in looking at these pathogens of interest, we know that the funguses, which are the largest particle size, still can be airborne for quite a while, and they don't have as much because bacteria is much more driven by people and funguses are much more driven by the environment. And that's not a hard and fast rule. That's Linda Lee's vision of the world. So that's my vision. So anyway, as these particles that were interested in disease transmission start to get to be in their micron size, we look at that in relation to, in this particular case, I was looking at in relation to UV intensity treatment. And this applies whether you're outdoors. If you can measure the UV intensity or you know the UV intensity, you can guess how long it's going to take for this virus to go away. And so in doing the mathematical modeling on all these, this just gave me a big list of things I was concerned about in particle sizing and exposure. So next slide. And this next slide is one that I think many of you might be struggling with or dealing with, especially if you're involved with the facilities people and picking technology controls. And in reviewing the list of people who are on here, many people are either nurses or work in healthcare or are school nurses or so on and so forth, some building facilities. So if you think about, this is our imaginary building. This is the building you work with. This is the school you're in. This is wherever. And so on the top of the building, there's what's called a package unit. It's an HVAC unit. It's when the air comes in, the air goes out and keeps you cool, keeps you warm, regulates temperature, humidity, everything throughout the building. And this is in the most simplistic form. So if you're a facilities guy, you're going to tell me there's Phoenix valves and there's building automation. There's all these things. Yes, I already know that. But the issue really is that all of the technologies that we talked about, so UVC, ions, HEPA filters, vaporized hydrogen peroxide, ozone, all those things get introduced here. Now, why is that important? That's important because the source is in our little team room here. This is where Bob just got back from his amazing vacation in Cancun and is telling the whole department about it with no mask, no social distancing, and is asymptomatic spreading. So what you're doing in the air handler on the roof, which is fine, is that you're treating every room the same. So the room next door, which might be Mary's office, is getting treated the same as the source where everybody's having coffee and talking about their vacation. And so the issue is that there's more contamination in that team room. So what I focus on is looking at source control. And source control in their simplest form being masks. But if you can bring those technologies to where the sources are, so conference rooms, classrooms, team rooms, areas where people are getting together in closed spaces, similar to our earlier slide, where you can really focus on controlling the source. Now, in our little diagram here, the blue lines are the air coming into the unit, into each room. Theoretically the same temperature, theoretically the same. There's mixing boxes, there's all sorts of things in between here, but theoretically, this is the way it works. And then the red lines are the exhaust back into the system. And so this goes on all day long. If you're a classroom, you might have, 30% fresh air. If you're a hospital, you might have, in an OR, you might have 100% fresh air. You might have 50% fresh air. Depending on the building code and the ASHRAE requirement drives all of these circumstances. And I sit on several ASHRAE committees for UVC looking at this. And right now I'm developing a standard actually for room air type of microbiological testing. So what we're looking at here is that all of these technologies. Now, my personal preference is I do not like any technology from a public health standpoint that introduces anything into the air. So hydrogen peroxide, ions, and so on and so forth. Because it treats everybody in the building the same. Now that's just a bias. Every one of these people will tell you that they're below the EPA limit, they're whatever. But at the end of the day, I grew up in the era where doctors smoked on TV and said it was really good for sore throats. So I don't like adding anything to the microbiology or to the chemical loading of a building. That's just a personal bias. And so I wanted everyone to understand kind of what actually goes on in these building systems and where the technology that you're considering is being introduced. So that as as a consumer of this, or as an advisor to this, or as the person maybe even charged with this, you can understand the differences. And I'm going to do the last slide very quickly, and then we'll open to questions. I'm sorry that I'm over. I know I'm going kind of fast. But these are some of the technologies that are currently, you can read about them all over the internet. And then some of the things that about them that I particularly look at. So these are currently some of the technologies that are out there for the air. And in summary, basically, last slide, is that we know that the SARS-CoV-2 virus behaves a lot like the SARS-1, except it's not as deadly, so to speak. So we're learning a lot about it. We know about asymptomatic, pre-symptomatic, and so forth. We talked about routes of transmission, indirect and direct. And we also talked about how fragile the virus is. But my favorite one is buckle up, because according to Dr. Irwin Medlitter, you see him all the time if you watch NBC or MSNBC or many other stations, the minimum is 2022, but probably we're into this till 2024. So we've got a lot of things we are going to do as public health practitioners to keep our communities and the people that we're advising safe. And so I'll open it to questions.
All right, well, thank you so much for this is super informative presentation. And we just have a couple minutes for questions. And I have one here that is a little long, but I think it's a great question. So it says, we stayed at a bed and breakfast inn when we visited Colorado, and they asked me about how long would be advisable to leave a room to cool off between guests. They do a thorough cleaning, but they do it themselves. I'm not sure that they have industrial type cleaning. They wait 24 hours or more, and then they clean the room. So there's 48 hours between guests. Is that enough or too much? Is there anything else they need to do regarding cleaning the room?
Well, it really depends on the air handler that they have, because there's air exchanges. So that's removing particles. It really depends on the humidity. This virus doesn't like the humidity between, say, 40 and 60%. That leaves enough moisture in the air to prevent a lot of the particles from drying out. And in those humidity ranges, they're more likely to stay on a surface. And so if they're removing these larger particles from surfaces before they dry, so there's some other questions to fill in those blanks. 24 hours is probably fine from a pathology standpoint if there's not a lot of protection to the virus, because it really doesn't like to live outside a host, but it's often protected by moisture, mucus, liquid, saliva, so on and so forth. So that's a hard question, not knowing any of these other parameters.
Right, yeah.
4 hours is a good number, especially if they can keep the humidity between 40 and 60%, which at least a lot of the research from Stephanie Taylor seems to indicate that you don't get a lot of drying. You don't get a lot of drying in this virus with those temperature humidities. But we're coming into winter, and those humidities are really hard for many environments.
Right. Well, we are at our time. We do have more questions. Dr. Lee, would it be okay if we emailed you the questions and you can answer them, and then we can put them on our website with the answers? Because I think there's some really great questions here.
Yeah, that'd be great. And if anybody, my email is up there. If anyone needs to contact me, feel free. And if I can help you, I'd be glad to also do that.
Great. And remember that we also will have this presentation on our website. Again, that is msdcenter.org. So you're welcome to go back and go through the slides and review, anything that you may have heard today. So I want to thank everybody for attending this webinar. And thank you, Dr. Lee, for a great presentation, very informative and somewhat depressing seeing the 2022-2024 dates on there. I'm hoping you're wrong, but you're probably not. Anyway, again, we appreciate everybody being here, and thank you for joining us today, and we'll see y'all next time. Bye-bye.
Thank you.